I'm Niki Hybben. I'm a physical therapist at Riley, and I'm excited to be here and share some information with you about physical therapy and how we help kids with and teens and young adults with SMA. So kind of from the start of this conference today, we've had a lot of good information about SMA and how it affects the alpha motor neurons, which greatly impacts the ability of the muscles to work. So upon diagnosis, it's really imperative for your child to be recommended for a physical therapy evaluation to determine their baseline level of movement, especially with all the new gene therapy and treatments out there for SMA now. I get to see the itty bitty newborns, which I'm super excited about, so that we can get them started and see where they start and watch them through their whole life. And the earlier we are involved, the better, and we can help with referrals with first steps or early intervention in your area and initiate that standardized monitoring across the lifespan. So kind of our role as physical therapists, we are your movement specialists. We assess, obviously, the child or teen's flexibility, their strength, posture, those big body movement skills. So like rolling and sitting, crawling, walking, running, how they're moving their arms and legs. The biggest thing, though, is that while we're assessing their movements and their range of motion, we're looking for symmetry. We want to know if one side is stronger than the other, is one side tighter than the other, and how easily are these movements performed. So looking at efficiency and kind of their ability to quickly move, or are they slowly moving, how they get around. One of the key things that I've been involved in at Riley are the standardized testing, not just with the infants with SMA type 1, but also the children and teens with SMA 2 and 3, and using those standardized tests at very specific intervals related to either Spinraza or right before they get Zolgensma, and then between 3 and 6 months after their treatment. We'll redo the test so we can say whether the child is progressing or they're stable, or we can show any regression as well. So the CHOP and 10 is the one for the infants with SMA type 1, and it is free to access to everybody. So even the physical therapists in the rural areas can get access to them through curesma.org. And the Hammersmith is also located there, which is a great tool that I've been able to give the therapists that don't work in Riley access to, and kind of guide them through testing the kids out in the rural area so they don't have to travel so far for these regular things. And then I'm also working on becoming certified to do the Bailey scales, because we're finding that as these, especially the infants with SMA type 1, they are doing really well. And I've had some kids max out the CHOP and 10, so we need something else to monitor their developmental skills in a very standardized way. So what do we do as far as treatment after we evaluate the child? Besides the standardized testing, which we recommend occur at a minimum every 6 months, so that we can get that standardized monitoring of function across there as they grow and see how they're doing. So when to start physical therapy, like a regular burst, it really depends on the child's presentation, and I don't have black and white guidelines, but except for regular check-ins are very highly recommended at 6 months for sure, and even 3 months. You can do a quarterly check-in just to see throughout the year how they're doing, if home programming is going well. Some of the key reasons that I would recommend as a physical therapist for your child or teen to come in for more regular or weekly visits would be if they're losing skills for whatever reason, things are getting harder, maybe we're going through a growth spurt, which is typically when things get a little bit more difficult. If there's a loss in range of motion, especially if there's a difference between both sides of the body, because it can affect so many things, from being able to lay in a good position or sit in their wheelchair or other chair throughout the day. If we need more regular home program updates and training, sometimes kids just need a little bit more direct attention to get things going at home. Definitely if there's any pain going on, or if there's a very high risk for decline without ongoing intervention. I'll talk a little bit more about insurance here in just a minute, but with the COVID, unfortunately, we can't sometimes bring our kids in because it's not safe for them to come out of their home. So I've had a pretty big increase in virtual visits here and there. And I can do the Hammersmith standardized test can be done virtually because it's all observational that you're watching the child move. I cannot do the chop and tend virtually, unfortunately. But also virtual visits can be helpful for just guiding you at home how to help your child. So after you've had that initial evaluation, ask the physical therapy team if they do virtual visits and kind of how to set that up, because it's better to keep you guys safe than to bring you out into our clinics. The types of treatments that we typically do, it varies across all ages and stages of life with SMA and the different types. However, stretching and range of motion is very critical across all types of SMA, because any type of limitation, again, especially the difference between sides, is imperative to treat and prevent from it getting worse. So whether we're using stretching or bracing, positioning, all of the above, we have to get a handle on it so it doesn't get worse. Because it affects their posture. If you have one leg tighter than the other, you're going to sit funny, and then that affects the spine going up the chair, and it can be really uncomfortable if you've ever felt a very tight side of your body. It also protects their skin and joints to have good range of motion and stretching done regularly, and it helps with just being in a better position throughout the day. We also work on training the children and teens with like efficiency and improving their ability to do the movements on their own. So rolling and getting in and out of that sitting position, or working with the caregivers on safe transfers, finding the best way to transfer your child if they aren't able to do it themselves, and then working towards standing and walking when those are happening. We are very good as therapists to meet your children and teens where they are at in their movement skills. So that's why it's very unique to every child. And then also, if you have the ability to get into aquatic therapy or hippotherapy, as mentioned before, those are great alternatives to standard therapy in a gym. Sometimes I'll have a kid go to aquatic therapy for a little bit and then come back and see me on land. And we'll just go back and forth as long as insurance continues to do what we need it to do so we can keep the kids moving. And as far as equipment goes, as a physical therapist, I typically deal mostly with standing frames. And it is recommended 5 to 7 times a week is the optimal frequency for standing in children with SMA type 1 and 2. And we try to start looking at a standing frame around the 9 to 12 month age window if they are starting to have good alignment to be able to get them into a standing frame. And we have standards that go all the way down to infant size. I mean, this guy in the picture, he's pretty tiny. Technology is amazing. We can get kids up on their feet pretty early now. But it's important to work specifically with a vendor to get a trial. They can do trials in-home now, as long as it's safe for everybody involved. And we typically just work with National Seating and New Motion in Indianapolis, but I know there are other vendors around as well. And then as far as bracing, we as therapists work with our physical medicine and rehab doctors and the orthotist to determine kind of what is needed when, because it honestly depends, and it's a balance of improving the child's posture and alignment, and also thinking about how the effect of the weight of the brace can affect how independent the child is going to be. But we do recommend that once we get some bracing in place, that it's worn up to 5 days a week. The time worn, in my professional opinion, will depend on what type of brace it is and what the purpose of it is for, because we have some bracing for stretching overnight and some for positioning so they can be upright better in their wheelchairs. So it really depends. So it's key to work with all those involved to get the best options for your kiddo. And as far as, so we go through, these are the things that we recommend, and sometimes, unfortunately, insurance likes to deny things. I haven't had too much trouble, honestly, in the few years that I've been at Riley, working with kids with SMA, getting approval for just ongoing therapy or quarterly check-ins and things like that. However, I have had a couple of kids where insurance was fighting back because we were in kind of a maintenance stage, and how do you keep therapy going? And well, you know, if a child is undergoing, especially any kind of the treatment, we need to keep eyes on them and work those muscles as much as we're able to so we can keep them moving forward. So it's important to initiate that appeal as soon as possible, as soon as we know. Sometimes, unfortunately, the families know before I know as a therapist. So keeping those lines of communication open so we can do our part of getting a hold of them or writing an additional note to advocate for your kiddos. Those standardized test scores are great ways to show insurance the stability of your child, or if they've shown some small improvements, ways for them to objectively see why therapy is important. And then advocating to the therapist, because I have worked with, had some phone calls with other therapists outside of my network asking, how do I, this is what I'm seeing, insurance is saying this, what do we do? And just really helping guide them on how to like pick out key pieces of the child's ability and what they're doing in therapy and why they feel it's necessary for them to keep going. There has been times where we've tried all these things and we get the big no thank you, and the child has to take a break. And unfortunately, that has happened a couple of times. And then what we've done is had them come back 3 months later with a new order. We do a new evaluation. And unfortunately, usually the child's regressed some, so it gives us really good information to say, hey, let's keep therapy going again. So don't stop fighting if they say no, because we really want to help your kids move forward. So that's it from me.
Hi, my name is Shelley Coleman Casto. Like Niki said, I'm an occupational therapist at Nationwide Children's Hospital. While I primarily work on our inpatient units and in acute care, I also do cover in our SMA clinic. And one of the things that I have found that has been really beneficial for me is that I get to provide that continuity of care from our clients that we see in clinic to when they get admitted to the hospital. There's at least one familiar face. And I think it just helps make the experience unfortunately, when you do have to get admitted to the hospital, it just helps make that a little bit easier, because you do have someone that knows your care and knows your diagnosis and knows what's going on. So that's one of the benefits, one of the things that I do love about my job. What I was going to start talking about today is just giving some general definitions of occupational therapy. One of the questions that I, as an OT, often get is, what is the difference between occupational therapy and physical therapy? And there are times, especially in infancy and early childhood, where OT and PT services will look very similar, but the goals behind what we're trying to achieve can sometimes be different, and that's where the difference in the different professions lies. So OT services can be provided for rehabilitation, habilitation, and the promotion of health and wellness for clients with disability and non-disability needs. Occupations to an occupational therapist are not just jobs. It's not just the job that you do, but it's the everyday activities that people do as individuals and families and with communities to occupy time and bring meaning and purpose to life. For an occupational therapist, achieving health, well-being, and participation in life through engagement in occupation is basically, that's kind of my elevator speech. It's the overarching statement that describes occupational therapy in its fullest sense. That quote acknowledges the profession's belief that active engagement in occupations promotes, facilitates, supports, and maintains health and participation. So my goal as an OT is really just to help you do the things that you want to do every day. If that is being able to brush your teeth independently, if that's being able to feed yourself, if that's being able to go to school and make it through the school day, really very client driven, very, very client centered and family centered for an OT. And so sometimes occupational therapists will talk about occupations and activities. Occupations are the things that they include the things that people need, want, and are expected to do. And it really brings personalization and meaningful engagement in everyday life events or activities. Whereas activities can be used with occupations to enhance occupational engagement or that participation in supporting the development of the skill that you're trying to work on. So occupations are made up of a lot of different activities, and whereas an OT, I tend to intervene, it's either working on that specific occupation, if that's being a student, or if there's one activity within your occupation of being a student that you were really struggling with or you want to work on improving, then we may use different activities around that occupation of being a student to help you to build skill and development. So categories of occupations. So when we talk about occupations, it's not just OTs don't just do self-care. We don't just do fine motor work. We are the handwriting people in schools, but we do also look at a lot of other different things. So to an occupational therapist, these are the categories of occupations that we really think about and talk about. And those are your activities of daily living. And that encompasses bathing, toileting, dressing, feeding, eating and swallowing, functional mobility, personal hygiene. And then we move on to instrumental activities of daily living. And these things include caring for others, caring for pets, driving and community mobility, financial management, religious and spiritual expression, and safety and emergency maintenance. We also will oftentimes look at health management, and that includes social emotional health promotion and maintenance, symptom and condition management, medication management, and personal care device management. A new occupation to occupational therapist, as our practice framework has recently been updated, and rest and sleep did at one point fall under general activities of daily living, but the research surrounding rest and sleep has become so important and imperative that the profession as a whole decided to split out and consider rest and sleep its own occupation. So looking at the occupation of rest and sleep, we're looking at sleep preparation, sleep participation, and the ability to rest. When we're looking at education or the occupation of education, that's formal participation in formal education or participation in informal education. When we're looking at the occupation of work, it's talking about employment interest and employment pursuits, job performance, volunteer exploration, and participation. And really the same when we're looking at play, it's looking at exploration and participation. The same with leisure, looking at leisure exploration and leisure participation. So with play and leisure, what an OT will do, depending on the age of the client that the therapist is working with, will really explore areas of interest and then work on helping to facilitate that active participation in those activities and in those areas. And then when we look at social participation, we're talking about community participation and being an active member within your community. Looking at family participation and what that means and looks like to you as a family unit. Looking at friendships and looking at peer group participation. So the role of the occupational therapist as a part of the treatment team for a client with SMA will depend on a lot of different things. It will depend on the age of the client. It will depend on where treatment is being provided, if that's in the home, either in early intervention and birth to 3 services or home-based services because someone is on homebound instruction from school. Therapy can be provided in school, can be provided in outpatient clinics, similar to what Niki was talking about for physical therapy. It could be provided on inpatient acute care units. I mean, really, those are sort of our traditional medical model areas of providing therapy, but you can also find OTs oftentimes in a lot of non-traditional areas too. I know and have colleagues that work as wellness coaches in fitness facilities or working in adult day centers, working in group homes. So really, what the OT is working on with the client is truly dependent on where services are being sought out, and will ultimately depend on the goals of the client and the family and the caregivers. One of the things that I think is unique to the field of occupational therapy as a whole is OTs will consider not just the occupation of the client, but co-occupations. So thinking about participation in activities that inherently require more than one person, and really thinking about family participation and meal participation, really encompassing the entire group dynamics and how to facilitate and actively engage in those group dynamics. So the way that OT sort of looks, and it really just depends on the age of the client too, like I said. And oftentimes what the occupational therapist will intervene on is dependent upon the facility or where you're working. So, like Nicole had said in my bios, I've had the opportunity and the experience to professionally work in a lot of different areas. And one of the things that I have experienced is it really depends on the colleagues that you work with, their areas of expertise, and how different organizations and facilities delineate that scope of practice for the different therapists. So an example that I like to give is I have worked in clinics where both the occupational therapist and the physical therapist will work on seating and positioning and wheelchair access. And what the role of the physical therapist in that clinic was really looking at posture and making sure that we achieve the best alignment and positioning in the wheelchair, whereas I, as the occupational therapist, was looking at access for drive controls in a power wheelchair. If we're looking at switch driving, where the switches should be placed, what type of switches we would be using. If we were using an alternative joystick, what type of joystick worked best if we're doing a head array and driving with the head. And so really OT looked at the access. And I've done the same thing with augmentative communication with some of my clients who have tracheostomies and are on ventilators and are looking for an alternative way to communicate because speaking over the speaking valve is so tiring. As the OT, I work with the speech therapist and really look at, is eye gaze the best option? If you're going to use eye gaze, how do we find that best positioning in that best area of access? So on this slide, I'm talking about early intervention, so really thinking about that birth to 3. At Nationwide Children's, one of the things that we have started doing is really looking at car seats and car seat positioning for our really young clients with SMA. One of the things that we have found in doing some car seat studies on some of our clients is that there can, if there is an adequate support within that car seat, that there can be a concern for oxygen desaturations and potential safety concerns related to maintaining a good airway. And so me, as an occupational therapist, I work with our passenger safety program, and we really look at seating and positioning and identifying the best car seat, if it's infant carrier, or as our clients age and get bigger, and really size out of those off-the-shelf car seats and booster seats, looking at medical car seats to provide that safe transportation, and what is the best car seat, what is the best positioning device, so that any of our clients can access their family vehicle and not be concerned for their safety. As an OT, I'll also look at feeding and oral motor development. At Nationwide Children's, oftentimes the occupational therapist will do the feeding and oral motor treatment for infants, so birth to 12 months. And then sometimes that will transition, if we're still looking at oral motor development, that skill will then transition to the speech therapist at 12 months of age. And that's when, as an OT, I would start looking at more self-feeding skills. So fork use, utensil use, finger feeding, the ability to tolerate the transition from different textures. If a child is having difficulty transitioning from baby foods to more solid foods, OT will work on some of that sensory sensitivity as well. The other things that we'll really look at is seating and positioning for floor time and that floor play, and being able to have that peer experience, and also looking at positioning for safe bathing. So looking at bath seats, bath chairs, just to make sure that all of our clients can access what they need to be able to participate in those activities of daily living. So then moving forward through preschool to school age, really we're looking at tolerance for play in different positions, while the physical therapist may be working on building the skill of those big motor skills. As an OT, I'm looking for, can you play in that position? Can you access and enjoy and have fun in that position, and really be able to interact and have that social engagement to build social skills and that peer participation? As kiddos are transitioning from preschool to school age, there's an increased demand for fine motor skills and fine motor work. And so we'll look at seating and positioning for trying to develop those skills, and making sure that our clients have the trunk support and the support of those big muscles that they need to really focus on using those small muscles in their hands. And if that's too hard, then we look at adaptive equipment and assess technology and access to technology for school participation to set our clients up to be successful. And then, like I said too, we also look at seating and positioning for peer interaction and functional mobility. So if that's a floor sitter, if that is a wheelchair or a power wheelchair that goes down to the floor and then up to table height, really looking at some of the different pieces of equipment to allow for that social participation and engagement in school activities. So then as we transition into late school age and into adulthood, we really look at addressing adaptive equipment, changing adaptive equipment needs. So in this picture, you can see that this client is working with an adapted spoon and using a long-handled spoon to try and feed herself independently. She's also using a mobile arm support to try and really develop that skill and proficiency with that piece of adaptive equipment for self-feeding. We know that our bodies change as we age. We know that what our bodies need, even even in general, changes as we age. And so that's where the role of the occupational therapist is going to change over the lifespan of our clients with SMA. We'll be looking at addressing technology to access computers, self-care devices, power mobility, and really working to increase proficiency and independence with that changing technology and the changing needs for technology. Because as young kids, our clients oftentimes don't need a lot of high-tech intervention, but as what I have seen is as our clients age, then we need to move to more higher tech pieces of equipment. And so really being comfortable with that technology. And then really as an OT working on self-advocacy, really working on teaching care and vocalizing what care is needed, and just being a self-advocate. And that's where the occupation of health and maintenance really comes in. And then really looking at recommendations for environmental modifications to improve access to home. So if that is, different cabinets, if that's looking at bathroom modifications for adapted bathrooms, the need for ceiling lifts, and other environmental controls that are either voice activated or using different types of switches to access some of the environmental controls that our clients need and want, just to promote that independence. This is my contact information. I am happy to be a resource, and just all of the definitions that I used and sort of that framework came from the occupational therapy practice framework, which is what we as OTs use to guide our practice. Thanks.
Well, hello, everyone. My name is Jessica Almanza. I'm a dietitian at Lurie Children's Hospital here in Chicago. And let's talk a little bit about nutrition and SMA. I have some important kind of facts or things that I wanted to kind of point out. And this is kind of in regards to how most dietitians and how I work with our patients. Definitely a very individualized approach. Everyone has unique nutritional needs, whether that's because of age, mobility status, activity levels, food preferences. We know that a lot of kids just in general are picky eaters, and then also cultural, religious food practices, whether we're in the middle of a pandemic or not, those all, take into account what our nutrition needs are. And there isn't a specific diet that is recommended. Again, very individualized approach, but we do have general recommendations that I'm going to be going over in terms of nutrient needs, as well as what kind of nutrition issues we see or are common, and when you should see a dietitian, as well as kind of what things are assessed during a nutrition visit. So in terms of nutrient needs, in terms of energy needs, with SMA, most needs are very similar to the general population, but they are a little bit lower, and we do kind of calculate energy needs a little bit different based on height rather than weight. And this has been it's a very general, kind of broad range, so it can really vary. And this is where, again, it's based on the patient, and a dietitian will take into account, different things when assessing how many calories each person needs. Usually it's increased if they're on ventilator support. So they're on vents, they usually require a little bit more calories. Fluids, we want to make sure everyone is adequately hydrated. So for SMA type 1, we do have a little more of a specific range to follow, and it tends to be a little bit higher compared to SMA type 2 and 3, where we usually use the dietary reference intake, which is kind of the general recommendation for their specific age group. In terms of micronutrients, which basically vitamins, minerals. Again, we follow the DRI guidelines for age, and we kind of make sure that if anything we know of a deficiency, that we supplement appropriately. And then we do focus and we monitor vitamin D and calcium, and that's mainly for bone health. And this could be supplemented or things, food that to be added to the diet, or added to feedings if that's the case. So in terms of the macronutrients, carbohydrates, protein, fat, very general again to recommendations to the general population. There aren't any specific things that are a little bit different. Carbohydrates is about 50% of our diet, and these are grains, breads, pastas, fruit, vegetables, all fall under the carbohydrate category. And protein is things like eggs, meats, some legumes have proteins like beans, for example. And again, we follow the recommendations. It's believed that depending on each individual person, whether more protein is needed or less, and that could basically because of decreased muscle mass. It's believed that it's not needed as higher levels, but usually we just kind of use the DRI as a guideline. For fat, over 1 year of age should be on less than 30% of total energy, which is very close to the overall recommendation. For infants, it should be less than 45. So infants usually do require a little bit more fat, which is sometimes why it's recommended for kiddos to be on whole milk, for example. And, we want to make sure that we're adding healthy fats to the diet, and that can be in the form of avocado, nuts, if needed, things like butter, but overall healthy, heart-healthy fats. Some nutrition issues and kind of the reason why I would see a patient in clinic would be with one of these feeding, swallowing problems, and we can kind of reach out to like feeding clinics and other professionals that work with us in clinic to kind of assess and work through some of these issues. But there may be things regarding textures that we can work with to kind of, if for example, kiddos prefer more soft foods, then kind of working with mom and dad to kind of see what more mashed potatoes, softer like fruits instead of like raw apples, maybe boiling them just to get them to eat a little bit more variety. There are ways to do that, and that's one of the things that I kind of brainstorm with parents about. Undernutrition is probably one of, and this would be undernutrition, malnutrition, basically not eating enough, lower weight, and basically working around kiddos following their own growth curve. So we look at the growth chart and we assess, are they following their own growth curve, or we kind of take that individual approach and kind of follow them along from visit to visit and seeing if there's any changes, whether that's weight loss or weight gain. We want to keep an eye on that and try to see what possible issues, what has caused that change in weight. And growth failure, again, we want to assess their growth overall and not just focus on one weight for example, from one particular visit, just the trends in general. There's a possible, inadequate energy intake. They're not eating enough. The formula is not enough. The volume is not enough. So we want to take, kind of into account how probably go through what they're eating in a normal day, and kind of have a rough estimate of how many calories they're taking, protein, and seeing where we can find opportunities to improve the diet. So there isn't a specific diet plan or meal plan that is recommended, but we want to make sure they're getting enough of the foods, especially the foods that they like, to make sure that they're getting enough. And then, of course, we do have kiddos on enteral nutrition, and whether that's for swallowing problems or not eating enough, it could be the main source of nutrition, or it could be supplemented. We do have kids that are on overnight feeds. So maybe during the day they're eating, maybe not eating enough, but we can, through whether it's a NG tube or a G tube, they can get some formula overnight, and that way we know that in 24 hours they're getting adequate nutrition. And this is, again, when you would work with a dietitian very closely to ensure that we know that we have a specific plan that determines appropriate formula type, that they're tolerating it well, that the volume is correct. And especially as kids grow, we want to make sure that we're continuing to assess their needs. As they grow, they might need more. If we're seeing rapid weight gain, we might need to decrease. As mobility status changes, we might need to make adjustments as well as just with activities. We might have more going to school or therapies, and we may need to do a little bit of a different kind of schedule so that their feeds meet the needs of their normal day. So some of these things are the things that we discuss during a visit, and we want to make sure that we answer any questions for parents, and to make sure that we're optimizing the diet. And see some more references. And that's it for me. Thank you. And here is my email for any questions that you may have apart from today's presentation.
Thank you, Jessica. I was just curious, and I know I get this question often, is there a website, and this is for you, Shelley, is there a website that you kind of go to for adaptive equipment to help people figure out, where they could look to find what would best suit their needs? Oh, you're muted.
Oh, sorry.
No, I did that earlier.
There's not one comprehensive website. Part of it is having a really good relationship with your vendors. So in Columbus, we use the Columbus branches of National Seating and Mobility and New Motion. And I think just with experience, I have learned some of the different brands. Riften is a company that I really like. For bathing equipment and for positioning. Permobile and Quantum are two of the power chair companies that we tend to use quite a bit. So, it's really just having the conversation with clients and with the families and with the patients that we're working with, and identifying those needs, and then trusting your vendor to help you with that piece.
And Niki, what if someone's insurance is not covering their physical therapy? And I know a lot of times there's a long stretch that some folks might go without physical therapy due to insurance costs. What would you recommend for those folks?
I typically recommend, if I'm not the one seeing them and they reach out to me, or maybe a therapist does, if they're close enough, I'll have them come see me and see if I can submit and try. Sometimes switching systems, if they've been in the system for a while, will with a new evaluation, but usually we just ask for a new order and try a whole new evaluation if it's been up to 3 months. I would say typically with kids with SMA, if they've been in regular therapy and they come out and sometimes it's harder to do those home programs, and do some of this stuff, they'll show some type of regression if you have a really good eval.
Okay.
I would say try again.
Okay. When in doubt, try again. And Jessica, we have a comment that came in, and it said that there's a lot of chatter in the SMA community about kids getting treatments with Risdiplam and Spinraza, which are now requiring more protein. And it says that they try hard to get the message out to have nutritional labs drawn once every 6 months. That's a best indicator for how we tweak the diet. But is it a good way to find out about the carnitine levels that was mentioned earlier today? I know one of our presenters talked about that. Or is there a way that we can get more protein in these kids' diets?
So yeah, I haven't heard too much about this, but I kind
Okay.
of started to hear, yeah.
Okay.
But in terms of checking, more than likely that it through labs.
Okay.
We know, and depending on their source of if they're on enteral feeds or oral diet, there are ways to definitely get more protein in.
Okay. All right. Well, thank you all three of you for your time this Saturday. We appreciate it.
Thank you.
You're so welcome.
Thank you all. Have a great rest of your day.
Thanks, you too.